Hi everyone, it's Naomi. My presentation is titled Central and Peripheral Findings. I'll be discussing the case of an adult male who had sudden onset of vertigo symptoms in May of 2022. These symptoms were accompanied by nausea and emesis, and it all started after he contracted COVID. At the time, he denied any pain in the ears, any tinnitus, any changes or fluctuations in hearing, or even changes in his vision, but he did report a history of occupational noise exposure as a plumber. Initially, meclizine was prescribed, and he did note some improvement from taking it. And he also reported imbalance when walking, especially, and he did have one fall because of his symptoms. The first assessment was completed on June 6, 2022. This was an audiological evaluation followed by an ENT assessment. The audiological evaluation revealed a moderate to severe sensorineural hearing loss from 2000 to 8000 Hz in the right ear, and a mild to profound rising to severe sensorineural hearing loss from 2000 to 8000 Hz in the left ear. TIMPs showed positive pressure in the right ear, and they were within normal limits in the left ear. Ipsilateral reflexes were present from 500 to 1000 Hz in the right ear and absent from 2000 to 4000 Hz. In the left ear, they were present from 500 to 1000 Hz, elevated at 2000 Hz, and absent at 4000 Hz. OAEs were present at 1600 Hz and absent from 2000 to 8000 Hz in both ears. The ENT that saw him deemed the findings of the audiological evaluation and his own assessment to be consistent with acute vestibular neuritis of the left ear. The patient was then recommended to perform Cawthorn exercises on his own for his dizziness. He was also recommended to schedule an MRI and have metabolic testing done. The MRI was completed in 2022 and everything was within normal limits. There was no evidence of any intracranial abnormalities. At that time, vertigo was no longer his primary complaint, but he was still feeling off balance. And he was also still performing those Cawthorn exercises on his own. He saw another ENT on August 24th of 2022, and this appointment consisted of counseling and education about his symptoms, but there was no further treatment or assessment performed at that time. The second assessment came about a year later on August 29th, 2023. The audiological evaluation was essentially the same as the one from the year prior in June. Everything looked about the same, including otoscopy, TIMS, OAEs, reflexes, all of that. He still had that moderate to severe hearing loss in both ears. The patient was seen again on the 29th of August after he completed some VRT sessions throughout the previous year since he initially started having these symptoms. The symptoms of imbalance while sitting and standing persisted, so the ENT thought that his symptoms were pretty consistent with persistent postural perceptual dizziness, or triple PD. The differential diagnosis included migraine without evidence of any other etiology. The ENT then recommended a VNG and started the patient on Effexor. He was also recommended to come back to the ENT in a month for follow-up. And then finally, he was also recommended to start another trial of vestibular rehabilitation to see if it helped. The VNG assessment was performed on September 20th of 2023, and the caloric irrigation resulted in a non-significant right beating nystagmus of 4 degrees per second, but there was an unexpected beat direction detected under the left warm condition. So if you look above here at this image, you can see that there's right beating nystagmus in the left warm condition where we would expect left beating nystagmus. There was adequate suppression of nystagmus in both directions with fixation, and everything was repeated. The irrigations were repeated and there were similar results, so we know that it's accurate. And there was no spontaneous nystagmus observed throughout any of the testing here. There was significant right beating nystagmus under all positional head conditions, but they did suppress with fixation, and the fact that they could be suppressed indicates a peripheral site of lesion. There was no evidence of spontaneous, gaze-evoked, or positioning nystagmus. The head shake test initially yielded a right beating nystagmus, but then that changed direction to a left beating nystagmus after about 20 seconds. There was adequate suppression with fixation, and then the testing was repeated just to make sure that something didn't just randomly happen. And we saw that again. He started with the right beating nystagmus and ended switching to left beating nystagmus. And then just in general, head shake nystagmus or post head shake nystagmus can suggest a lesion of central origin, but it can also be influenced by the patient's inattention to the task, drowsiness, medication, anything like that. But the direction changing nystagmus itself does indicate a central lesion. All other tests, visual tests of the central nervous system and ocular motor function were essentially within normal limits. The results of the VNG revealed peripheral and central findings. The third assessment was on September 29th, 2023, during which he saw an ENT. This was after using Effexor for about a month, but there was no improvement noted. The persistent sensation of disequilibrium was still there despite multiple interventions and evaluations. So because it was determined that it was both a peripheral and central disorder, there was a recommendation of tertiary care consultation at UCI. This case is relevant because many people live with some degree of dizziness or imbalance, but are often convinced that it's in their head and don't do anything about it. There is testing to be done, though, to rule in or out anything or different pathologies. And although the answers aren't always black and white, there are different avenues to pursue treatment. And this case really helped me grow as a clinician because I was involved in testing someone who felt desperate for answers. Counseling him was really challenging, and at first I feel like he didn't trust me because he's been to so many different providers and he hasn't gotten any answers, so he didn't really feel like this was going to help. But ultimately I did earn his trust, kind of just talking him through, listening to his concerns and things like that. And although we didn't quite reach a solution from this testing, he was happy to learn of the results, because then he understood that no, they aren't just in his head, like he had convinced himself. After we discovered that there were some central and peripheral findings, he was almost relieved that kind of like at least there's something there. Even though it's not a positive thing, he's glad to know he's not just making it up. Thank you everybody for your time.